and those who are online. I'm very pleased to introduce Kazem Rahimi, who's Professor of Cardiovascular Medicine and Population Health at Oxford. And he's going to talk to us about the changing paradigm in the pharmacological treatment of elevated blood pressure.
Thanks for having me here. So the title sounds quite exciting, doesn't it? We're going to change the paradigm. So I'm going to go very slow about some of the work that we have been doing. It is up to you to make the judgment on work. I could only move the slides. Here you go. So assume that most of you are not much aware of what has been going on in blood pressure research. Just start giving a brief historical overview of research in this field in the 20th century. At the beginning of the century, we didn't have much information about blood pressure at all. That was the time when we started measuring blood pressure, and everybody thought that the elevated blood pressure in older age is just a normal process of aging. And it was in the early 20th century when the first reports of association between blood pressure and death came about. And these were not actually scientific studies that showed that association. That came from the US life insurance claims data, where the companies found that people whose blood pressure was higher were more likely to die. It was not until 1950 when the Framingham study, the cohort study, showed that association between blood pressure and risk of cardiovascular disease, but to also show that there was no common perception of elevated blood pressure being a problem. The famous case is Franklin Roosevelt, the former US president, who had a terrible lifestyle, but he had very good physicians who were meticulously recording his health status. And it is said that he died of a stroke with his blood pressure being 300 over 190. But just a year before that, his doctors were diligently recording his blood pressure, and it was recorded a year before that, 186 over 108. And they thought this is just normal for his age. It was in 1960s when we had the first interventional studies, drug trials, showing that lowering blood pressure can reduce the risk of cardiovascular disease. But that message did not get across to the clinical community. The classic textbook of cardiovascular medicine, Friedreich's diseases of the heart, in 1966, made a claim that treatment of individuals with a blood pressure of less than 200 is not indicated. So they set the threshold of things being bad at that level. So we get into 1990s when we came up with meta-analysis, and the first large-scale meta-analysis, work done by Stephen McMahon and Rory Collins. And this was a meta-analysis of observational data, the paper published in The Lancet in 1990, where they combined information from 9 observational studies, 9 cohorts involving 420,000 individuals. So here on the x-axis is the usual diastolic blood pressure, because at that time, the common belief what it is the diastolic blood pressure that we need to be concerned about more than systolic blood pressure. And on the y-axis, the relative risk of stroke to the left and CHD to the right. And what this study showed is that the relationship between diastolic blood pressure and risk of cardiovascular outcomes is continuous. So there is no threshold below which the association changes. It appears that it goes all the way down. That work was extended by Sarah Lewington and the Prospective Studies Collaboration about 10 years later. This is also individual patient data meta-analysis of observational studies, 1 million individuals included in this study. And by having such a large data set, they could, of course, go deeper. They could stratify by age, sex, and a number of other patient features. And this shows the relationship between systolic blood pressure and ischemic heart disease, death from ischemic heart disease to the left, and to the right, it is the same relationship between the diastolic blood pressure and ischemic heart disease. And as you can see, these are stratified, these floating absolute diagrams are stratified by age. So in each age category, there is the same relationship that was shown in the earlier meta-analysis is hold. The y-axis is a logarithmic scale. Absolute risk of individuals suffering cardiovascular disease, of course, increases with age, but that relationship, that continuous relationship goes across all age categories, all up to 80 to 89 years. It's some flattening of the of the curve, or this less steep in older age categories, as one probably would expect. So for epidemiologists, that appeared to be the end of the story. We have nailed it. We have shown that the lower the better. This is the paradigm, and off you go. The challenge is that paradigm of the lower the better has not translated into clinical practice and treatment decisions to date, and there's ongoing controversy about it. So of course, one of the key challenges to that observational data is, does it apply to medical interventions? I mean, showing that people with the lowest blood pressure have got the lowest risk is one thing, but does it work also if you reduce blood pressure from whatever levels you start, bring it down? And the next question to that has been, of course, as is appropriate in most observational studies, we tend to exclude people with prior disease to reduce confounding and reverse causality. That, of course, leaves the question from clinicians' point of view, how about people who have got pre-existing conditions? How do those findings apply to those individuals? And that gap from those large-scale, properly designed and conducted observational studies have been filled by a number of other types of observational studies that have confined the population to those with disease. I'm just showing one example of a study that was published in Lancet in 2016, that was in people with pre-existing cardiovascular disease. So the average person that a cardiologist sees in the practice. And they showed association between blood pressure, systolic blood pressure to the left, diastolic blood pressure to the right, and risk of cardiovascular disease. And what you see here is the typical so-called J-shaped curve association. So it appears to be that there is an optimum for systolic and diastolic blood pressure, above and below which the risk seems to be increasing. And these are observational data. Of course, they're prone to reverse causation and confounding, but the interpretation of such results have been that we should be careful about intensive blood pressure reduction in people who have got pre-existing conditions. So in order to address that, of course, there are different ways of doing it. The best way to change practice is randomized clinical trials. Of course, it's very hard to conduct randomized clinical trial in every subgroup that people might be interested in every baseline. One efficient way of investigating is in an individual participant data meta-analysis of randomized clinical trials. So in the next few slides, I'm going to go through some of the results that we have done as part of the BPLTTC, the Blood Pressure Lowering Treatment Trialist Collaboration. So this is a collaboration of clinical trialists of trials that have intended to lower blood pressure with one drug versus another, comparing one drug with another drug, or a strategy of more versus less intensive blood pressure lowering, with the requirement that these should be larger trials, at least 1,000 person years per trial arm. So the collaboration was established in 1998 and has been quite influential. The beginning establishing, that there isn't much difference between different classes of drugs, and lowering blood pressure is a good thing. But to address those questions about effects in different subpopulations, we started a new cycle of the collaboration in 2014 and started really collecting more data from these trials that have been completed. So now we are to the point where the collaboration has access to over 50 clinical trials involving over 360,000 randomized participants. So this is individual level data of people who have entered into clinical trials, not knowing what they would be taking in most trials, over an average of about 5 years. So let's go to some of the results. I mean, one of the first questions using that resource that we investigated was, does the effect of treatment depend on an individual's blood pressure before initiation of drug therapy? To address that question about that there might be an optimum, that there might be a level below which we shouldn't go. And also at the same time, there's this, that if there is a threshold, is it going to be different for people who have got a pre-existing disease and those don't? So this shows essentially a forest plot where those 350,000 individuals were stratified into 7 groups according to the baseline blood pressure. So from less than 120 mmHg all the way up to 170 mmHg or more. one thing to flag, once you get that large data set, you suddenly get a large number of individuals who fall into the blood pressure category for whom we don't have any separate trial. So most trials have included people whose blood pressure was above 140, the classic hypertension population. But when you get that individual patient data, you see there are thousands of individuals who fall into that low blood pressure category where there is the greatest uncertainty. And when one essentially standardized these analyses for a 5 mm reduction in systolic blood pressure and looks at the outcome of major cardiovascular disease, so this is the typical outcome that is looked at in clinical trials of blood pressure lowering treatment, and this consists of hemorrhagic stroke, ischemic stroke, heart failure, or myocardial infarction, ischemic heart disease. So that is the definition of major cardiovascular disease. So there is no evidence of any traction, so implying that reducing someone's blood pressure from 170, let's say, to 160 would lead to same relative risk reduction, everything else being equal, compared with someone's blood pressure coming down from 130 to 120. So that 10 mm mercury reduction would roughly reduce the relative risk of individual by about 20%. And to go further, where a more intensive blood pressure reduction is good, one can conduct a meta-regression. So here on the x-axis is the difference in blood pressure reduction between the two arms of the clinical trial, with each of those circles being one of the clinical trials included in the analysis. And on the y-axis is the hazard ratio for major cardiovascular events. And this plot roughly implies that the more intensive reduction the blood pressure across the trials has been done, the larger the proportional effect. So some of you might be familiar with that. This is the story that we have known, of course, in the context of cholesterol. A few years ago, we have shown that the lower the cholesterol, the more intensive lowering of cholesterol, the larger the relative risk reduction. But for blood pressure, there has been, of course, some concerns that you need to have some level of a blood pressure for functioning. I mean, the cholesterol, it seems to be accepted that it can go all the way down to almost zero, but no one would essentially make the same proposal for blood pressure, because blood pressure zero is essentially dead, right? But now let's go to the subgroup of people with disease or without disease. So, having that IPD individual patient data meta-analysis, one can classify the population into people who have had previous cardiovascular disease and don't. As you can see here, the hazard ratio for a 5 mm mercury reduction in cardiovascular disease is almost identical, 0.89 compared to 0.91. Overall, no evidence that the treatment effect would materially be affected by people's pre-existing condition or not. But of course, the more critical question is, do we have aim for different targets of blood pressure? Should we not treat people based on their blood pressure? And this is, with such a data set, you can do essentially subgroup of a subgroup. So people being classified in the top who had known previous cardiovascular disease, and in the bottom, people who had known previous cardiovascular disease, so essentially a primary prevention population. And when you do that stratification, you get the same result. There is no evidence of interaction. So that essentially dismisses that observational evidence that I've shown before of a J-shaped curve being causal. Now, the next question and that the clinical community and guideline community throw at us is, does age matter? That J-shape continues. I mean, you can't get rid of the J-shape. Once you answer one question, someone else comes with a whole lot of other studies just saying, oh, in that population, we should make a distinction. So a number of studies, and again, I've selected one suggesting that in older people, that J-shaped curve is actually shifted towards the right. In other words, older people need for their physical functioning or physiological functioning, that their blood pressure should be kept higher. So if we go lower, they might suffer some events. And that was, of course, a good case for us to just test that hypothesis in the BPLTTC. Classifying people into 5 different age groups. And of course, the absolute risk in younger people is lower, but roughly speaking, the hazard ratio for a 5 mm reduction in systolic blood pressure, which roughly is equivalent to 1 class of drugs given over long term, was consistent, with the exception of the oldest people. And we had pre-specified, of course, the analysis going 85 plus. So if you go into the 85 plus years category, then the data becomes sparse, the uncertainty is larger, and hazard ratio 0.99. So if you like, there's a bit of an uncertainty in that range, and there was some suggestion that probably in the younger people, the relative risk reduction is stronger, which is also consistent with some of the observational studies because of the lack of competing risk and the longer duration of treatment in some of those individuals. But of course, for clinical decision-making, what matters is the absolute risk reduction. And when you plot the absolute risk reduction for each of those age groups, again, as one would expect, despite an apparent diminishing relative risk reduction in older people, the absolute risk reduction tends to be larger in older people because they're more susceptible to suffering a cardiovascular event. But the more critical question on that sort of J-shaped curve papers is whether we should not treat older people whose blood pressure is above a certain range. And in a sense, it's getting a bit repetitive and boring. If you do that here again, you stratify each of those age groups according to different systolic blood pressure categories, no evidence of an interaction. So essentially that notion that we should not go low in people above a certain age is challenged by this. So far, I mean, what we have seen is that, using that large data set, doing stratification of treatment effects, what we have seen is in terms of relative risk reductions, the effects are largely consistent across different age groups, across different systolic. I haven't shown also diastolic blood pressure risk. I haven't shown doesn't matter between sex, whether you're men and women. And it doesn't matter for many of the conditions that people have had. I mean, I've shown it for cardiovascular disease. One can do it the same for atrial fibrillation. The findings are largely consistent. The only group in whom we have found an interaction is people with diabetes, interestingly. So people who have diabetes, it appears that the relative risk reduction is substantially weaker than people without diabetes. But again, given that the decision is based on absolute risk reduction, and given that on average people with diabetes are at higher risk, that the relative risk reduction difference was essentially negated when it comes to clinical decision making. So we've gone all the way along to trying to find whether stratification, whether there's any subgroup that would benefit substantially more than others. The responses, we have come to the point to just say, no, in fact, it applies to everyone. So far, we have not identified a subgroup that would substantially benefit than any others. And in fact, we have shown that we have got strong evidence that reducing blood pressure, even in people who are in the sort of a normal range blood pressure, would translate to similar benefits. Now, as I've said, most of the focus has been on cardiovascular disease prevention, defined as heart failure, hemorrhagic stroke, and ischemic heart disease, which, by the way, is slightly different than the prevention of statins, where we know that they don't work on hemorrhagic stroke, and there's a bit of an uncertainty in terms of heart failure, at least not as strong as we see here. But what we know is, blood pressure lowering and is likely to have intended or unintended effects on a range of other outcomes. And that is in part some work that we are planning to do. But one investigation that we did, which I think is important, is the effect of blood pressure lowering as well as antihypertensives on risk of diabetes. That follows on from some observational epidemiology that we had done and others had done it as well. This is using the UK EHR, and these are floating absolute risk diagrams for diastolic and systolic blood pressure respectively, and risk of people developing diabetes. So these are people without diabetes. We just look at the blood pressure that has been recorded in the EHR by the GPs, and then you follow them over several years, on average, I think for about 9 years, and you look at the proportion of the people developing diabetes, and that shows that people who had the lowest blood pressure have the lowest risk of developing diabetes. And the relationship 20 millimeter mercury higher systolic blood pressure is associated with a 60% higher risk of diabetes. So these are, again, associations. These are observational data, and the relationship between diabetes and blood pressure can be complicated. The two go together a lot of the time. So the question arises whether these findings are causal. And this is a work that we did with George in collaboration, where we essentially triangulated the user-median randomization as well as the BPLTTC to look at whether blood pressure reduction has an impact on risk of diabetes, and it actually showed that it does. So that evidence from observational studies is confirmed. So if you lower blood pressure, not only do you get benefit in terms of prevention of major cardiovascular events, but in terms of relative risk reduction, the magnitude of the effect is very similar. So hazard ratio of 0.89 for a 5 millimeter reduction in risk in systolic blood pressure. As I said, they were confirmed by using Mendelian randomization as well. So to just summarize, I think if you look at the history of blood pressure research to the present time, and that is why I provocatively said that this is a changing paradigm. I think in 2021, we have come to a point where we can just say we have extended the evidence that we have had from blood pressure reduction working to just saying it also works in people who have got an apparently normal blood pressure and largely irrespective of their age, sex, and many of the other clinical features that people thought it is important. That, of course, creates a lot of tension. I mean, for you, as epidemiologists, you may say, oh, that is obvious, right? Get on with it. But in the clinical community and from public policy perspective, it creates a lot of tension. How should you make decisions about treating? And one question that I'm often asked is about that notion of a normal blood pressure. I mean, is it a good thing to treat someone whose blood pressure is normal? Where do we go with this? I mean, you can see that, I don't know if there are any GPs in the room. A lot of time they're concerned, geriatricians are concerned, just saying, where do we start? I mean, we can't treat everyone with drugs, and we are over-medicalizing it. So, I mean, I alluded to this fact earlier that we need to have some level of a blood pressure to be able to walk and live, right? We can't get it all the way down to zero. So the question is, should we define a target just saying this is a good thing and that is the level that we should accept and not go below that? And how do we define norm? Of course, normally what we mean with normal distribution is an average of the population. If you look at the UK's average blood pressure in 2011 from population surveys, in men 129/73, in women 122/72. Should we define this is the norm, this is where we should go, everyone who is above that we treat, everyone below that we don't treat? We could just say, well, I mean, it's great that we live in the UK, but surely UK is not the center of the world. And you're right, if you just look at the global picture, it looks very different, all right? This is just from the NCD risk factors collaborations evidence. You see the blood pressure not only differs substantially across different regions of the world, but the pattern of its change over time is also qualitatively not the same. In some places, most places goes down, in fact, in some places goes up. So that complicates things if you want to just come with a norm that you define. And we know that, the blood pressure is also changes in many countries by age. So as well as sex, as I've said before, and these are again, UK data, cross-sectional data looking at blood pressure in different age groups. And what we see is roughly a continuous rise of the systolic blood pressure in men and women, and diastolic blood pressure goes up to middle age and comes down. So that creates, of course, a number of challenges. Do we need to have country-specific, sex-specific, age-specific norms that we define? What would be the purpose of that? So I think the way we should look at it is to look at populations who have not been exposed to our industrialized lifestyle, because we know what drives blood pressure is largely lifestyle. This is salt, this is alcohol, this is sedentary lifestyle that leads to elevated blood pressure. Unfortunately, we are lucky that we've got at least 2 studies that have been conducted in rural populations who have not been exposed to those things that I've just mentioned. And the Intersalt in 1988 and the study by Müller in 2018 that go essentially in those rural populations, look at the individuals' blood pressure. And if you plot that, a couple of things become apparent. First, it doesn't seem to be a great difference between men and women. The second thing is it doesn't seem to go up. It seems to be flat across age groups. And the third thing is they're all sort of centered around 90 to 100 millimeter mercury systolic. So to me, if you want to just search for something that would be physiologically something that we need, that is probably the level that we should look at. And I think that is important in terms of thinking about it, about, that we're not causing too much harm. That is probably the level Everything above that, of course, the story is a bit more complicated, but everything above that is likely to be our lifestyle. And that means that we should at first not confuse the normal, that is the population mean, that's something that is optimal. And most of us living in Western societies with a lifestyle are likely to have an abnormal or elevated blood pressure. So that helps to some extent. The question is still, how should we treat individuals? Before I go into how we should select individuals and what evidence we have there, another confusion to dispel is about how effective drugs are. Sometimes people think that, give someone a couple of tablets and the blood pressure could get it down from 180 to 100, and that is quite unsafe. And if you do it at the level of individual, as GPs do, you may get that impression because blood pressure measurement is so noisy. Even without treatment, it goes up and down. And a lot of time, you would make misattribution about the change in blood pressure that is actually not due to treatment. So a better way to look at it is to look at, of course, randomized evidence. You look at blinded fashion, or in the sort of a control environment about how much does a drug affect an individual's blood pressure. I showed this regression plot earlier, and as you can see on the x-axis here, you haven't got actually many trials where on average over several years the blood pressure has been reduced by more than 15 mmHg. So if you're honest, this is the range where we have got confidence about safety and effectiveness of blood pressure lowering. Everything else that goes beyond that is an extrapolation and certainly not supported by interventional studies. And one can go a bit deeper into that, and we can plot that at the level of individual and over time. And in the BPLTTC, as I said, there are 3 types of studies that we have included. Here now, I'm just displaying the results of the 2 types of them. To the right, placebo versus control. To the left, those trials have aimed to just do a more versus a less intensive treatment. And what the figure shows that, for a placebo-controlled trials, that means one drug being added in a controlled environment of a clinical trial, of course, where where adherence is monitored, what people take outside of a trial a lot of time is controlled. You get roughly something in the order of 5 or 6 mmHg reduction in systolic blood pressure. That is why, the results that are presented earlier are standardized to that level, right? And even in those trials of more versus less intensive, where people are allowed to use multiple drugs, what we see is blood pressure reduction in that controlled environment of going maximum to about 12 mmHg systolic blood pressure reduction. I think that is important to just bear in mind that, of course, at the level of individual, and if you combine, 4 low-dose drugs, we have got some evidence over short term, you can get it, lower to 20 mmHg or more. But it's fair to say that this is roughly the evidence that we have with the existing drugs. That is why I think it's important, and the pharmaceutical industry is just now getting into the phase after 15 years of no development at all to trying to come with alternative drugs that might be better tolerated and be more effective. But let's get to the question about who should be offered treatment. So this is the distribution of blood pressure in the UK population using EHR. I mean, this is roughly what you would expect. Most people will fall into the category of 130 to 139. And if one follows them up over some time, a fraction of them will develop cardiovascular disease. And the proportion of people developing cardiovascular disease in those people with a higher blood pressure is going to be larger. If one looks at global estimates from global burden of disease, we know that there are about 10 million attributable deaths due to elevated blood pressure globally every year. The group that is considered for treatment traditionally is that group where the blood pressure is above 140. But if one puts that in the context of how many deaths are attributable to blood pressure, about 3 million of those 10 million fall into the category where the blood pressure is below that threshold of treatment. So we need to come with a selection approach that would lead to the largest absolute risk reduction. So we need to pick up people who are more likely to benefit from it, because treatment, even if they don't cause any adverse events or harms, they still incur a cost. Someone needs to implement them. So what is the strategy of choosing people? And here another work from BPLTTC we looked at risk-stratified approach. So any individual, you predict the risk of cardiovascular disease, give them treatment to look at what is the relative risk reduction of cardiovascular disease. And what we see, there is no interaction according to the relative risk. But of course, people who have higher risk will get larger benefit, and that is plotted here. So on the x-axis is the intensity of blood pressure reduction, on the z-axis is the risk of individuals, and on the y-axis, the cardiovascular events avoided. And as you can see, the higher the predicted risk of an individual, the more intensive blood pressure is reduced, the more gain you get. The number needed to treat is going to be higher in those individuals. And this graph just plots the relationship between predicted risk of cardiovascular disease, color-coded, 10 to 19% is light orange, orange 20 to 29, and greater than 30% is red. So what this is to just highlight is that in those sort of groups of individuals who are considered to be hypertensive, of course, that triangle, there's a fraction of the people who might have a single risk factor that is high, but they're going to be ranked as having a low risk of cardiovascular disease. So if one thinks about over-treatment, that is probably the population that is being over-treated now, if they receive treatment. But on the other hand, we've got this bulk of individuals in this rectangular shown who will have a predicted higher risk and they're not offered treatment. And there are other studies that have shown that in each of those, those normal, so-called normal blood pressure category, the predicted risk of cardiovascular disease varies 30-fold. So despite people having, of course, the same phenotype of blood pressure, they might have substantially different risk of cardiovascular disease. So you know that by now, so blood pressure is not a good discriminator of the risk, and I've shown the evidence for it, but if one compares it in studies, different strategies of blood pressure-based selection, risk-based selection, or other types of strategies such as age-based, it is the risk-based strategy that trumps the other approaches all the time. And to just illustrate it with 3 hypothetical patients. So let's assume you've got a woman, 10-year predicted risk of cardiovascular disease is 20%, blood pressure 145/80. With a couple of pills, you're likely to reduce the systolic blood pressure by about 10 mmHg. That would roughly mean a 20% relative risk reduction in cardiovascular disease, 4% absolute risk reduction, or number needed to treat 25. So you need to treat 25 people like this lady to prevent 1 cardiovascular event over 10 years. This is what we're doing now, in a sense. Another person, it's very identical in terms of the risk, but her blood pressure is lower. Of course, numerically is quite predictable. If you treat this lady, reduce blood pressure by 10 mmHg, you get the same relative risk reduction, same absolute risk reduction, number needed to treat is the same. But someone, let's say she's hypertensive, blood pressure 180 and 150/80, predicted risk is 10%, so she falls in that triangle that I've shown. In fact, she falls in the category that is treated now. If you treat individuals like her, the number needed to treat is much higher. So 50 people like her needs to be treated over 10 years to prevent 1 cardiovascular event. So if it comes down to efficiency, the evidence so far suggests if you want to cut out not treating individuals, it is patient of the profile number C, not B. And at the moment, what we're doing is the reverse. If we stick to the recommendations. Of course, the question arises about harms. I haven't mentioned anything about other side effects of the treatment, but conceptually, we can divide them into 2 categories. So there are some that are specific to a drug agent, so the drug-specific harms of the treatment. And there's one category that is mediated through blood pressure. That means, the lower the blood pressure, the greater the harm that you get. So, but mathematically, if you put that in your head, that is not a differentiator between any of these groups, because the way I have shown these cases, in each group, they get 2 drugs to reduce their blood pressure by 10 mmHg. They get the same drugs. So there is no reason to assume why drug-specific harms need to be different, or harms related to intensive blood pressure reduction should be different in one or the other. It sounds straightforward, but conceptually, you would be surprised how people confuse that. You know, they think that, you know, because the starting blood pressure is lower, they're more susceptible to harms of blood pressure lowering treatment. That is not the case. At least we haven't got any evidence to support that thinking. So, as I said before, I mean, you know, as we answer one question and test one hypothesis, it seems to be the community is much faster becoming the more J-shaped curve associations challenge the finding, just saying we should not treat certain groups of individuals. And what we've been doing before, just a couple of slides on that one. Of course, we haven't got data for stratified analysis of every subgroup that people might be interested. I mean, the clinical trials are selective. They heavily underrepresent certain patient populations intentionally to enrich for risk, and people with certain conditions are a lot of time excluded, right? So we've been doing some work where we think, you know, we're using complex EHR that deep learning models can help with causal inference. I won't mention anything about Mendelian randomization because you guys know much more about it than we do. So I'm just going to go into that model of causal inference with a model that we call T-BEHRT. So what this is essentially, just imagine, you know, you've got your EHR. It consists of longitudinal data that, you know, time stamp data and some static data about individual. Let's say that is the sex. And the BEHRT model, which is a deep learning model that is you know, the type of transformer-based model. It can predict outcome, but in the sort of a causal framework, it does three things at the same time. It uses that deep learning framework for predictions, propensity score prediction, essentially assignment to your exposure group. It does the same thing for your outcome. So that is a framework that in statistics, many of you probably are familiar with. The targeted maximum likelihood, or, you know, the doubly robust approach where you essentially look at the outcome as well as the exposure at the same time. But it does a third thing, the mask EHR modeling, where the confounders in an unsupervised fashion are being predicted as well. So through that, it can capture potentially some latent confounders. So I won't go into details of it, and I'm not the expert as a clinician to mathematically explain all of that, but that has been validated in a number of studies. But I'm just going to show one case study where that was tested for challenging the so-called J-curve phenomenon in people with COPD, where in BPLTTC simply we don't have the data for that patient population, where you know, this is a patient group that tends to be at high risk of cardiovascular disease. They receive a number of treatments that also can affect their blood pressure. You know, the steroids that they receive or the inhalers can affect their blood pressure. And the conventional regression modeling, the studies that have been done have shown that there is an apparent J-curve. So here, that is sort of the two models that you can see here in the lower section of the figure here. With that T-BEHRT model, that almost disappears, and certainly there is no evidence to suggest that there is an idea that below which you shouldn't go. And the technique is quite promising. I mean, certain assumptions, of course, as with all modeling, needs to be met. You need to have the right data. The question needs to lend itself, but for certain complex scenarios, it works much better than the simple linear regression. And the advantage, of course, of these deep learning models is that you don't need to worry about pre-specifying all confounders. Of course, I know George might come just saying, you know, have you thought about colliders and all things? But, you know, in practical terms, it doesn't matter for many of those questions that we have investigated. Of course, it's not a panacea by all means. But it also works for some drugs. I'm not going to show the evidence for that at the moment. Of course, if you look at drug effects, the selection bias is a big problem in EHR and in any data set that you look at. But if you choose the right comparison, it performs better. And, you know, if this kind of discussion, I can refer to some examples that we've done, which look interesting. So, going from using secondary data of previous clinical trials to using EHR in populations that have been heavily underrepresented in clinical trials. Now I'm getting to sort of a third category of patients. So there are patients in the context of blood pressure lowering. There are those patients who are older, who are frail, who are multimorbid, where in every clinical guideline that you look at across the world, they're mentioned that we need to be careful about this patient population. there is less concern that treatment in these individuals is not going to lead to cardiovascular disease prevention. The concerns are around that, frail people and older people, they might have a sort of a short life expectancy, and to these people, short-term outcomes, that is physical functioning, cognitive functioning, matters more than perhaps the prevention of stroke or MI 2 or 3 years down the line. And the challenge that we have, that type of outcome data has not been captured in EHR on clinical trials of said if the patient has not been represented, you can't answer that question with secondary data. So that requires some prospective studies going ahead. Of course, the solution is clinical trials, right? But as you know, clinical trials, we don't do enough of them, principally because they're just so complicated, and I think they've become unnecessarily complicated and costly. And for people who want to just solve a problem, unless you've got a company behind you who's got a commercial interest in the product, you have to just see what funding you can, of course, secure to testing the hypothesis of your interest. So a few years ago, we started working on developing digital tools for patient recruitment and management in clinical trials, in a way that we can automate a lot of the processes in clinical trials that are quite time-consuming and require expertise, administration, people being involved. So that is one aspect of it that could potentially make clinical trials more efficient. The second aspect is that in clinical trials, what makes it them also costly, that you need to essentially manage clinical sites. You need to bring patients in, see them, visit them, ask them questions, consent them about the study and have follow-up. That is costly for the people who pay for the clinical trials, but I think that is also costly for many patients, in particular if you look at older, frail people. Just traveling to the hospital to have some routine assessments is a disincentive for them to participate in clinical trials. So what we thought, just let's bring the technology to those people. So let's let them stay in their home environment wherever they are, and trying to just do all the processes of recruitment and management in the home environment. So that led to a end-to-end clinical trial management platform that we call Zista, that can do a lot of those processes substantially more efficiently than what has been done before. It lends itself for the more conventional clinical studies. It can be also done for site-based clinical studies. But for those virtual or decentralized or home-based, different terms used for that, it is essentially designed for that purpose. So we started doing a pilot randomized study a couple of years ago that came just before the COVID lockdown. So where all prospective studies were halted, but we were fortunate because we're not having any physical interaction with these patients. We could actually go ahead and do this study. A study called Attempt Antihypertensive Treatment Evaluation, Multimorbidity and Polypharmacy Trial, and Thames Valley study, just one site. And we managed to randomize 231 patients. And in that study, the question is, if you go all virtual, how do you reach the patients? I mean, we experimented with multiple routes. We used an online pharmacy that could essentially invite the clients to participate. We went through the social media advertising route, and surprisingly it worked really well, even in that age group. Average age was, I think, 78. And went through this very painful route of NHS Digital that many people, I don't know if any people here have experience with, I would not recommend. But the other routes definitely worked well, and we got to the numbers. And the way it worked, you just invite people, they get into a sort of a website, and you could have a proxy people get into that website. They just watch a clip about what this study is about. They provide e-consent on their own. Of course, if they want someone to speak to them, it can be done. Pretty much everything else is done remotely. Direct dispatching over post. If there are tests to be done, we send actually someone to their home to just do the blood test, but that was a bit expensive. We want to just for the next study just move it. But what was very interesting, it was an experiment to engage with these people, right? And at the end of the study, we did a survey to just see how people liked it. The whole platform was, of course, developed with participation of patients or lay individuals. You can't see the statistics here, but the third line here is probably good enough. Would you be willing to be considered for the next phase of the trial? And 96% said yes. They were so keen. They were just engaging, because the advantage is that you're in a home environment and you've got experience an apparent adverse event, you reported immediately, or some of them were admitted to hospital in a different place, and immediately that report came through, and you see that all the time, and you could communicate with them remotely. And for us, one of the questions was, can you, through that system, it's nice to engaging with people, but if they don't take your drug or you can't get the drug to them, you have lost, right? I mean, that was the question, because it also works similar to what you would expect in conventional clinical trial. And these are the results. So doing the remote change in the drugs, we achieved the primary goal of about over 10 mmHg difference between the two groups, and are now in the process of going for a large trial where the purpose is to measure the cognitive function as well as physical function through wearables as well as digital tools, as well as, of course, their outcomes on clinical on cardiovascular endpoints. So, I mean, the tool, I mean, if there's anyone interested, is the platform. I mean, we have offered it to other units that are using it. I think it works well, but I stopped there. Any question?
Stop sharing so we can see some online questions. So thanks for really wonderfully clear. Any questions, either online or in the room?
I could ask lots of questions about the really exciting science because it was all great and loved it all. I'm not. Do you think that you got such positive reports from your trial because it was lockdown with lots of elderly people that felt like they were contributing to something? Do you think you would actually see the same level of success not in COVID?
Yeah, I don't think that the lockdown has had much impact, but one of the advantages of going remote is you're not confined to a circle around centers of excellence. That is what happens normally in clinical trials, right? You've got a hospital, and people in the sort of a 5 miles radius are those who are likely to just come to your study. People in rural areas won't, and that is actually an issue. So here, you could reach out to people who are living all over the place. I think that plays a role. The other factor that plays with it, I mean, that of course the intervention matters, right? This is a blood pressure intervention study. A lot of people know about it. This is an older people feel that they need to pay something back, and also they can't reach to the GP. They feel like if I'm participating, I'm getting also something back as well. At least I know that someone looks at my blood pressure. I mean, I don't know if you've heard, but since COVID, the treatment of chronic diseases has had suffered a great hit. Because people felt that they shouldn't go to the GP or to the hospital, or because GPs are just overwhelmed. So that has played a role in that as well. But whether the response rate is 5% or 10% or 20% doesn't matter really, because we're looking at a large fraction of the population who would potentially be suitable for the study. So, and if the recruitment is cheap, by sending an email or a message, you don't need to worry about what fraction you get into. Just remaining in this study is more critical, of course.
So Yoav has a question, but I haven't got the technical ability to unmute him. So you're going to have to type your question, Yoav. I can't work out how to unmute you. Oh, hang on, here we go. I think you're.
Oh yeah, now it's working. Yeah, I think it's just a bit slow.
Can you? Yeah. Oh, can you hear me? Hold on. You can't see me, but don't worry about it. Kazem, I just wanted to challenge the assumption. You gave two scenarios where we currently wouldn't treat because someone's blood pressure was below an arbitrary cutoff, but there were benefits, and someone where we currently treat, but because they're at low risk, you argue that may not be the right thing to do. So it's the second scenario I want to just challenge you on, because as we know, the greatest predictor of your cardiovascular risk is simply your age. So if you have somebody whose risk is 10% but has high blood pressure, and you say, let's not treat them because their risk is low, in 10 years' time, their risk will now be 20%. And in that 10-year period, their brain, heart, and kidneys will have been exposed to a higher blood pressure level than they could have experienced if you had actually treated them with a drug. So when their risk goes up, in 10 years' time because they're older, they will have had more end organ damage through that exposure of untreated blood pressure. So isn't that an argument to say, no, you should treat these people because, okay, in the short term, the numbers needed to treat may not be that good, but in the longer term, as their risk goes up because they're older, you will have reduced their risk because of the cumulative exposure of that sort of the area under the curve of their blood pressure?
Yeah, well, that's a great question. That is exactly the thinking that has led to the guidelines to be written in a way that they're written. Then my response is, just imagine you're a healthcare provider and you can afford to treat 100 people. That is really the decision challenge, right? Are you going to start treating those who you know are low risk and 10 years down the line, as you've just said, might suffer some complication? Or are you going to focus on those who are likely to, without treatment, die in the next year, right? You could just say, I want to just do both, but that is that unfortunately the resources are finite and you need to make decisions. But even on the sort of a scientific level about choosing who you want to treat, the notion that you get end organ damage without treatment, so therefore treating earlier is a good thing, is of course correct. However, that is being confused with treatment having a sort of a cumulative effect over time. And
so you should be standing down.
Okay. Okay. So and the literature on that is fair to say that it is conflicting, but in my view, there is no evidence as such that essentially if you treat over a longer period, the relative risk reduction of the treatment is going to be larger. So it's all driven so far, as far as we know, by absolute risk. And the curves start separating, unlike some of the statin studies where there seems to be a latency. For blood pressure, it seems to be, for those outcomes that we look at, there is no cumulative effect. So it starts pretty much from the day that you start treatment. So that goes against that as well. So, but in an ideal scenario, if you could afford it, and if there are people willing to take it, and if the harms are minimal, yes, you're right, that should go. I just give a scenario that you can choose between patient B or C. And I think in that case, for most health systems, probably B would be a better choice.
So presumably no one's done a delayed versus immediate treatment trial in this sort of intermediate risk group to see whether there are real long-term benefits?
Well, I mean, that would be difficult to design. But, one thing that, in fact, George and I talked about combining Mendelian randomization with BPLTTC is there are different ways of looking at it, right? I mean, in the RCT field, you could essentially have stratified by period of follow-up and essentially run the model saying treatment effects, hazard ratio, year 0 to 1, year 1 to 2, and so on. You could do that. But glancing at the Kaplan-Meier curves that I've just shown you earlier does not suggest that there is a divergence of the curves over time. So I would be surprised if we see an interaction of treatment by time. But there are other ways of looking at it that one should look at. But one thing that is interesting that I don't know, that is why I didn't say categorically that is not the case. The sense that I'm getting that it depends a bit on the outcome that one looks at. You could imagine that, I don't know, for an outcome like dementia, I didn't talk about it at all, but there's actually good evidence that the prevention of that is also works with blood pressure lowering, that there might be a latency, there might be a lag effect, and you need to treat for several years to get that. I don't know. I mean, there are some uncertainties there, but certainly for stroke prevention, for cardiovascular disease, we haven't seen that delayed effect that would justify to just saying we don't treat patient B, because just imagine you have to make a decision. You can't treat everyone. So the scenario is I won't treat patient B, I treat patient C. And I don't think we have got enough in that sense. And there's of course observational study that can answer that question as well. We looked at it using EHR. You can look at essentially, as you just said, area under the curve or cumulative effect of blood pressure over long term that had, in terms of relative risk, had an element of prediction, but in terms of adding to the overall prediction of cardiovascular disease, didn't make any difference. So in other words, using a single blood pressure at one point in a multivariable risk factor versus adding a cumulative measure of a risk over several times, your AUC of your, let's say, Q risk was the same.
Okay, thanks very much.
So maybe we'll go to Angus's question first before Emma's, because Angus's follows on from yours, which is, how do we think about young people with hypertension where lifetime risk may be more important than 10-year CV risk?
Yeah, no, absolutely. I mean, that is a great question, and I think it follows from what we discussed before. It depends on what you look at it. I think in terms of lifestyle, you're absolutely right. The message should get across that don't assume because you're young and your blood pressure is moderately elevated, you'll be fine because you will pay the price for it down the line at some point, right? Statistics speaking. But in terms of health services and management, you have to make trade-offs. And I think we haven't got evidence to just saying we will focus and treat people at younger age because they're susceptible to risk over a lifetime and not treating. I mean, one interesting approach that the European Society of Prevention has taken, just saying we actually reduce the threshold, the predicted risk in younger people. And they supported the notion by what we've said here that the lifeline risks might be higher. And interestingly, they cited some Mendelian randomization, saying Mendelian randomization gives us essentially cumulative effect over lifelong. And I don't think that you can compare them necessarily as apples with oranges. Made that case. But I think in terms of economic decision making from public policy, it does not make sense for drug treatment to just go that far.
Excellent. Emma's question is there any evidence that adherence is poorer in intensively BP-treated populations, e.g. when BP management, like in the SPRINT study, moves into the community?
I think generally, I mean, that doesn't apply to blood pressure lowering. What we see that in these long-term trials, even in statin studies, the adherence within clinical trials is at the end of the study something in the order of, if you're lucky, 70 to 80%, is not 100%. So the reason why I'm mentioning it, when we essentially measure, quantify the effect of treatment in clinical trials, we are not correcting for that adherence. So complete adherence outside of the clinical trial setting would mean that actually the relative risk reduction is going to be larger. So we have essentially diluted the fact, we have taken already that lack of adherence in clinical trials into account. But of course, we know outside of the clinical trial, the challenge is bigger. There is a lot of people don't take drugs, and unfortunately, those who are at a higher risk tend to have a problem of not taking drugs. We have got a huge socioeconomic divide here in terms of adherence. But in more specifically about SPRINT, and the relevant question is if people take multiple drugs, if the adherence drops. I think in people who've got multimorbidity, people who take 10 drugs already, taking 12 drugs make actually very little difference. But people who want to start the first drug at one drug is too much.
Great. So it's 1 o'clock and we've answered all the questions online. But thanks so much again for a really, really clear, great talk.
Thanks, Mark.